Okay, so as I mentioned, I'm a urology registrar. I'm currently away on leave seeing my in-laws. So if you hear any noise in the background, do excuse me. I attended a football game at the weekend and, like to do things with family just to keep busy. So urology is definitely a specialty that can still give you a good work-life balance and quality of life. I'm training part-time, so if you have any questions about that at the end or getting into core surgical training, if you're applying in the next window, do feel free to think about those questions and explore that as well at the end of this session. So just going through the topic of hematuria, I want us to be able to go through some of the ways that we come up with our differential diagnoses, some of the important factors to consider when you're exploring the history, and lots of the investigations or the important investigations that are worth considering when you're assessing a patient. And then we'll talk about the immediate management and lots of the tubes that we might use in urology. Because I'm sure, in just all the different specialties I saw there, you'll probably still have patients that may have urological past medical history, catheters, nephrostomies, etc. So you've probably, come across these different surgical sieves. It's an important way of kind of unpacking what what some of the differentials in for hematuria might be. And on the left, we have like the things that we look out for most in with hematuria. We want to make sure we are considering the possibility of that is one of the things that are at the top of our differential list. We want to considering trauma. It's not always, very dramatic types of trauma like renal injuries or pelvic fractures. Very often much lower level trauma, such as catheter trauma, can be the things that bring patients to our attention or might cause visible hematuria. And we also want to explore the possibilities of stone. Does anyone have any questions just about that? I can't see the chat box just yet, so I'm just gonna try and see that alongside. Can you guys still see my screen? Perhaps Joe, could you give me a thumbs up? Can you still see my screen?
Yes, we can see it. Thank you.
And okay. Thanks, because I can't see the chat box at the same time. That was the only concern now. Thank
It's
you.
fine. I can
In
keep an
urology,
eye on the chat
we
box
have
if that's all right.
Okay, thank you. Just let me know if any questions come through. So in urology, we have a one-stop clinic in most centers where we can bring patients in for an assessment, a flexible cystoscopy, and ensure that they have relevant investigations such as an ultrasound or CT urogram. So if it's visible hematuria, we want to get a CT urogram. If a patient has non-visible hematuria, an ultrasound of the kidney, ureters, and bladder would be sufficient. And then also importantly, getting a flexible cystoscopy. So I describe that to patients as having a thin telescope put through through their water pipe so that we can visualize the bladder on a big screen and see if there are any structural abnormalities for why they've developed blood in the urine. So like I said, the thing that we want to exclude most is a possibility of a bladder cancer, which may be the case in almost 20% of patients that present to us with visible hematuria. Quite a large cohort might have had urinary tract infections, so it's important to explore the urine microscopies and cultures and find about other parts of the history, such as dysuria, pain when they're passing urine, and whether they've had any symptoms like this before. Like I said, the causes aren't always surgical. They might be renal causes. We also have stones as well, making up some of that as well. And then there are some things that might masquerade as causes of hematuria. So particularly when we have referrals from there was one that came through the other day that made me consider, does this patient need to be seen by gynecologists as well? So it was an elderly lady that I believe was incontinent, and when she was referred with hematuria, there was actually a possibility that with blood on the pads, there was a possibility that it wasn't actually from the urine. So as well as completing our hematuria assessment with a CT urogram and flexible cystoscopy, we wanted to ensure that she would have a workup from the gynecologist as well to consider was she experiencing post menopausal bleeding. Some drugs may change the color of the urine. I think rifampicin is one of those. Some people might have, changes in their diet or might be on a health kick. Maybe they're drinking beetroot juice to keep their blood pressure down, or, other kind of very red vegetables. So these are other things to be aware of. Patients who are dehydrated, people who've gone on, excessive marathon runs or various things. These might be other causes of having a redness or a brown tinge in the urine. So those are other things to kind of have at the back of your mind as you're taking a history and exploring, what are the recent events that have led a patient to present with blood in the urine. And then also skin contamination. Um, so sometimes people might have kind of vulval dryness, or a kind of vulval inflammatory change that could lead to kind of to blood on their urine depth. So when you're exploring a patient with taking a history from a patient with hematuria, perhaps you're in the surgical assessment unit, or A&E, like many of you said in the chat, you're in ED. You kind of want to take a focused history of these patients. It's really important to explore whether the symptoms are painful or not. Often patients that we are concerned about who have bladder cancers don't have a pain. You want to consider fever, whether the patient could be septic, and making sure you manage that quickly. If they have raised temperature or any other kind of SIRS markers, and you want to make sure they've got antibiotics within an hour, fluids, O2, and you've completed that kind of septic management. It's worthwhile for urologists to consider what part of this stream the blood is in. So whether that's at the beginning of the stream, which usually means it's at the distal part of their urethral tract, so in the of their urological tract, so in the urethra, blood from the urethra, that is, or if it's in like the middle of the stream or throughout the stream, it's more likely to be from the bladder. Hope that makes sense. It's important to explore whether there are clots, because that is usually one of the main thresholds that would trigger an admission to urology as well. If the patient has visible hematuria with clots, that would be a kind of strong indication for an admission. and three-way catheter and irrigation. So just to kind of hope that helps to strengthen your referrals as well when you're, calling to make a referral, surgical referral. Just these are some of the things that might be helpful to have asked about and explored in your history, whether that's in GP, ED, etc., and or on the wards if this happens to a patient and spontaneously on the wards, so that you can make a referral and touch some of these points, of things that might be going on. And also, it's important to explore whether they have any other urological symptoms. So lower urinary tract symptoms, I'm sure you've explored in different stages of your career so far. There are a couple of different categories: voiding and storage LUTs. So the voiding ones are the irritative symptoms, which are usually classified as frequency, urinary urgency, urge incontinence, and also nocturia. And this group kind of this kind of constellation of symptoms may, be present for a patient who has an overactive bladder. Patients might have it, with recurrent urinary tract symptoms as well. And there's also the symptoms that you might associate more with a benign enlarged prostate, such as hesitancy, a poor stream. And these are things that we explore in the urological clinics, where we might get flow rates and kind of work a patient up to explore they have an enlarged prostate, etc. So just kind of considering some of those symptoms, because you could experience, seeing a patient in the ED who's had an episode of hematuria or a UTI, and these have been triggers for retention. And when you explore whether they've had LUTs, you see, okay, there has been a long history. They probably do have a benign enlarged prostate, and you're just kind of ticking or mentioning those points again whilst you're making a referral to urology. So that can be helpful. And then obviously exploring all the other kind of parts of the history. And I just have that little iceberg in the corner, because it's also important to think about all the other patient kind of ideas, concerns, and expectations. But seeing blood from any part of the body, I always say to patients, can be, very anxiety provoking. So it's important to kind of be aware of how they might feel about these symptoms, and be able to give a sense of reassurance that there are investigations available. Sometimes you may almost be like halfway breaking bad news if you do think something is wrong, but doing that with a sense of context that you will make a referral, and having being able to describe these are the investigations that the patient will need to pursue. All right, any questions just at this point?
No, so far we are very good. No
Okay.
questions yet.
Well,
thank you very much.
well, guys, feel free to jump in if anything comes up for you, or you want to just vent even about referrals that have been challenging, because I know not all of our surgical colleagues might be easy to refer to. So just let us know if there's anything that you want support with. Okay, so investigations. It's important to consider OBS and from different perspectives, like, is the patient's blood pressure low? Are they tachycardic? Do you have concerns about a lot of whether they've experienced a lot of blood loss? And initiating relevant bedside tests. So often urine dips might be done, even before you see a patient in ED. Sometimes they're not. So just important to make a point of asking for that. And in urology, it might seem unusual, but when we do suspect a UTI or pyelonephritis, we like to send off urine cultures, even if the urine dip isn't positive. Like maybe there's just leukocytes of protein, but we'll still want to explore what's, what grows, if anything, on the cultures. So getting a full panel of bloods, relevant bloods, so FBCs, coag screen, Usenes, and group and save. I definitely want to highlight the value of getting a group and save, because when patients do have profuse amounts of hematuria, you just don't know what the HB will come back as, and it's helpful to have that, in done early on if you did need to consider a transfusion at a later stage. We've explored a little bit about the imaging already. Yeah, and just considering different modalities and how they might be relevant to different patient groups. So, for example, if you are, if you are called, say you're surgical etc., and you're called to a patient that has experienced trauma, you after they've had a trauma CT, if there's maybe loin bruising etc., you might want to consider a CT renal to get further information about the kidneys, whether there could be a laceration. So that that's one type of specialist scan. Things like a CT, a KUB, a plain CT might be done where you're considering whether the patient might have a ureteric colic. So where there's, maybe intermittent loin to groin pain, that would be the type of valuable scan you would go for. Ultrasounds, you might go for an ultrasound, maybe for a similar type of patient, but in a young female of childbearing age, that might be the scan to go for. But all of these things, if you're unsure, definitely speaking to your, senior and talking it through, or speaking to the on-call radiologist to ask for advice, would be a good idea. So, CT urograms are one of urology, our choice scans, because we want to know whether there could be urological malignancy. So that would be the scan of choice to be able to visualize the ureters as well, which the ultrasound wouldn't, which would be a limitation of the ultrasound, for example. So that's again why I kind of distinguish the point of when we have visible hematuria, because bladder cancers are much more common in that group. We would want a CT urogram, whilst they're much less common with non-visible hematuria. An ultrasound scan would be acceptable. And when we have, in urology, we do accept patients for hematuria workup. We get this flexible cystoscopy, which I described earlier. If you haven't seen one, or looked up, or consider what it might be like, it's the flexible cystoscope. It's about 18 French, so it's the width of like a large catheter, and we're putting that through urethra to get the tumors in the clinic. It is about like a 5 or 10 minute procedure, but we're able to give the patient the information straight away, and from there, if they were to have a bladder tumor, we can book them straight away for what you might see, the abbreviation you might see, TURBT, which is a transurethral resection of a bladder tumor in theatre. So that would be done as a 2-week wait procedure, so that can be analysed in the lab, and their further treatment could be guided from there, depending on what stage and grade the tumor were to be. Any questions at this point? No. Okay.
No, so far everybody seems to be following very well. Thank you.
Thank you. All right, so this is probably the wordiest slide, but I just wanted to kind of summarize the kind of takeaway messages from the NICE 2015 guidelines about visible hematuria. I think I've said most of this already about, how we investigate and what groups. It does just give like an age, let's say a couple of age cutoffs here, which is helpful. And also, I think this is the helpful points about, if symptoms recur after treatment, because in this line here, visible hematuria that persists or occurs after successful treatment of urinary tract symptoms, that's something that I think is really important to highlight for elderly ladies who, may go to their GPs with hematuria a couple of times, where they may go down the pathway of thinking it could be a urinary tract infection. We definitely wouldn't want a bladder cancers to be missed if that were the case. So just being vigilant about, what cultures are available for the patient, which is why we like to send them off. Did anything grow? Because if that wasn't the case, we might need to think, does this patient really have a UTI, or is there something else going on? That's the importance of just getting the GP to complete a 2-week rate referral to consider bladder cancer to our hematuria clinics. All right. Oh, I think I skipped one slide. Just to explore kind of management pathway. It's always helpful to, particularly for, assessment settings, to just help, particularly when you're in A&E or just going through an A to E assessment approach and considering, what interventions can you make in each category to, stabilize the patient and to assess the patient and like kind of stabilize anything that you see isn't right. If the patient is stable and, you can then move on to, what type of management you need to initiate, whether that's conservative, medical, surgical, completing all of your documentation, etc. Obviously, if the patient isn't stable, how can you resuscitate them, get a senior review if you have any questions, and initiate any further investigations. All right, so I just wanted to go through a few cases where you can chip in if you have any differential diagnoses that come to mind, or put them in the chat. If you saw this 45-year-old man who's come to your, I don't know, were many of you in, I think that, a few of you said you're on GP, so you probably have nice 20-30-minute consultations. If you saw this man in the GP clinic, what things would you want to explore in your history? Feel free to write that in the chat. And what differential diagnoses might be at the back of your mind. If you've seen blood in, so, that's really good, exploring weight loss and symptomatic features. Are there any LUTs? Considering, are there any clots? That's great. Because, this man, he was resistant to coming into the GP, but his wife encouraged him to, to attend. He's had blood in the urine a couple of times and it's not been painful. So it's great that I've seen you'd want to explore what volume of blood is in the urine. That's really good. Was there any trauma? There wasn't on this occasion. Sexual history, that's really important. Blood in the initial urine or throughout the, so I can see you guys have taken note of, considering what part of the stream that's in. That's really good. And travel history, infectious signs, that's great. Often people aren't very good at engaging with, genital urinary medicine. So, if you had any other concerns, it's definitely worth making that referral if you think that's appropriate. Family history, that's really key. If there's any history of other urological cancers. But ultimately, in this case, with everything that you gather, it would really be very important to make a 2-week wait referral to the Hematuria Assessment Clinic so that he can get those 2 key investigations, the CT urogram and the flexible cystoscopy. Awesome. And in this case, if you don't mind just doing the same thing, so you might see this patient, for example, in the emergency department, a 76-year-old gentleman who has blood in the catheter bag. What are the things that you're thinking about? And I'm sure many of these, comments that you've made in the chat would be relevant again. Was there any trauma? And it's quite possible, he's had and the nurse has replaced the catheter just the previous day. Was it a difficult exchange? That's really helpful to gather. So you might want to get some collateral history as well. Yeah, information about the catheter, whether it's been pulled out, is the patient distressed? Because that's again something very common, to get referrals to ED from residential homes or psychiatric care homes, etc. Just with patients who have pulled out catheters before. Are there any infection symptoms? That's really important. Looking in the tubing, is there gunk, biofilm, and is the catheter blocked? That's really helpful to gather whether it needs flushing, resiting, whether it just needs replacing. Is there any flank pain? That's helpful. Is the catheter working? So if it isn't working, if it isn't draining, you would definitely want to look at just going through those steps of potentially either flushing the catheter, repositioning it by deflating the balloon, pushing it right to the hilt for a man, so the balloon is definitely in the bladder, and filling up the balloon. If the catheter looks like, funky, it's probably worth exchanging and considering. Like one of our colleagues in the chat said, could there be infective things going on? Maybe the patient needs working up for a catheter-associated urinary tract infection and appropriately started on antibiotics. So you'd probably want to look at the guidelines for the antibiotic choice, maybe discuss that with microbiology if relevant. What's that? So whether the bag has been changed since insertion or any further bleeding. Yeah, great. Thank you, everyone. And I think I had just, oh, I thought I had one more thing. Oh, I put in a slide here about shock, just to consider that again, patients may not lose a profuse amount of blood, from hematuria, but it's just worth just having an awareness of this framework, particularly if you are interested in doing ED or a surgical specialty. I think this comes up in the ATLS a course as well, so some of you may be considering that, and just having a sense of the classes of shock and what parts of the vital signs might be affected in each class. So yeah, that's what this slide is about. Oh yeah, I did have just one more case. So you are referred this 29-year-old female to the surgical assessment unit with dysuria and visible hematuria and mild left-sided flank pain. What are your thoughts? Maybe put in the chat box what might your differential diagnoses be, and then what investigations might you want to consider. Pyelonephritis, yeah, that's a great one. Yep. Is it true hematuria, or is there another thing, something else going on? Gynae history, sexual history, that's all very valuable. Yeah, is it lower or upper UTI? Yeah, considering gynecological differentials like ectopic as well. Assess sepsis, yep, and you want to treat that very quickly. And any other systemic symptoms. That's great. So I've mentioned as well that she's had similar episodes like this in the past. and the cultures have been positive for E. coli. So perhaps this could be a presentation of pyelonephritis. But it definitely sounds like she has recurrent urinary tract infections. So you'd want to, and yes, looking up antibiotic resistance. So that's why it's, again, very valuable to have that kind of history of the urine cultures and sensitivities so that you can guide and rationalize her antibiotics appropriately. Fevers, what antibiotic has been treated with before and any resistance. Yes, that's really helpful information to gather when you're assessing this patient and making sure you're kind of putting them on appropriate treatment. So vitals, yeah. So we haven't mentioned scans. What kind of scans might you want to get if you think that's relevant? Yeah, ultrasound KUB, that's great. Yep, that's great. I think that's probably the typical and go-to answer. It's definitely a safe answer. If you might want to explore or discuss with your senior, or again, if you're referring to urology, you may discuss, with us and, or have made the referral. And sometimes, say if there wasn't any kind of infective history as well, uh, we may, for maybe an older age group, consider CT if we had a strong suspicion of stone. But in this case, I've given you very loose cases. I haven't said, okay, it's, intermittent loin to groin pain. Yeah, it's worth considering, could this be a ureteric colic as well, or could there be an infected obstructed system, which is, you know, kind of slightly more complex scenario where there's an infection as well as obstruction, and the patient still needs to be their urological system still needs to be decompressed. So that they could benefit from calling the interventional radiologist to consider a nephrostomy to decompress the system, uh, or being referred to urology for a ureteric stent if that was an infected obstructed system. And I think I got a case like that in my CRISP course. I don't think that's a course that's like mandatory for core surgical or completing core surgical training anymore, but it's care of the critically ill surgical patient. And it's another one of these courses similar to ATLS, where they want to explore how you are able to manage and assess a patient that's acutely unwell. So thank you everyone for chipping in and giving some exploring those cases. So yeah, I don't have too much to say on this slide, but it's just to consider, I've just mentioned about ureteric stents now. So, if you were to have, if you'll be to be looking after a patient that perhaps has a ureteric stent, or, they've been referred to EDs, sometimes let's say a case that I might think of, a patient might have a ureteric stent and they come into ED with some mild loin discomfort, or suprapubic pain, and these overactive bladder symptoms I mentioned earlier, so maybe urinary frequency and urgency. Sometimes that can just be, those can be unfortunate side effects of having a ureteric stent in place. So maybe they just had one placed last week because they had a ureteric stone. And this is, in urology, this is our way of temporarily managing the stone until we perform a definitive operation, something like a ureteroscopy and laser ablation of the stone. So sometimes patients can have symptoms associated with stents, which we just call stent symptoms. And it's helpful to be aware of that, just because patients can often respond to anticholinergic treatment, such as solifenacin, to kind of quiet down or minimize the overactive bladder sensations just while they have the stent in place, or tamsulosin, which could also be helpful. And if you are, considering referring patients, just getting some background information about when the stent was put in or when it's due to be changed can be helpful. So just don't be alarmed if you are dealing with patients like that. Just kind of look for some background information, like what operations were done, etc. Similar for nephrostomies, you'll find them in the patient's like flank area. So don't be afraid to just have a look under the dressings, consider whether they're blocked or not. Be confident, if you just want to assess that and ask the patient, does it look the way it usually does? Has there been any trauma similar to how you would assess a catheter, whether a lot of the tubing is out or not, whether it looks like normal. So just exploring that with the patient's help is helpful, and ultimately making the referral to the appropriate specialty ourselves. And we've talked about catheters already, so how to just consider whether they're blocked, if they need flushing, etc. So yeah, this is what I hope we've covered in uh, uh, a bit of an overview today. So just how to take a focus history and some of the key points to think about and explore when you're assessing patients with hematuria, what the differential diagnoses might be, and how to support your referrals to urology as well. So hopefully you have an understanding of the investigations that are key, how to safely manage a patient with hematuria, making sure you have gotten things like coag screens, group and save, and being vigilant about shock and sepsis, which are some of the kind of bread and butter things that we want to be confident at, particularly at as you're completing the foundation program. Those are some of the key things just to be confident with, and just how to manage things like catheters if you see them in an A&E or etc. So yeah, if you have any questions at this point, or just want to talk about you know your referrals, or want to talk about surgical training or anything, just feel free to ask away. Thank you, everyone.